Good evening, everyone. I welcome you all again in our very interesting series of detailed discussion and dialogues in Indian diabetes, that is 4D 2.0 program. Uh, Today we have a very interesting topic lined up for discussion, and it's about a disease, I believe, which is associated with one of the most severe forms of morbidity. Not only morbidity, but it's also one of the common reasons of mortality in patients with diabetes. We'll be talking about diabetic kidney disease, the prevalence of diabetic nephropathy in India. We have a very experienced speaker for today's talk. Our speaker is Dr. Ashok Chakravarti. Lined up for this talk, Dr. Ashok will be talking on the prevalence of diabetic nephropathy in Indian patients. Uh, Dr. Ashok is DM in endocrinology uh, from Andhra Medical College, and before that, he pursued his MBBS from Guntur Medical College and MD in General Medicine from KMS Amalapuram. He is currently working as a consultant endocrinologist at Ashok Diabetes and Endocrine Center since October 2019, and he has multiple publications to his credit. So we welcome you, Dr. Ashok, for this talk. Uh, Welcome.
Yeah, thank you, Dr. Atul, for introduction. So you discussed about this diabetic kidney disease. There's a lot of patients with people with type 2 diabetes. They're suffering with diabetic kidney disease. Who patient with long duration of diabetes, who uncontrolled, poor glycemic control. They're suffering a lot with this problem with diabetic kidney disease, and finally end up with a lot of morbidity, and finally end up in going for dialysis or going for renal transplantation. So we're going to talk about this prevalence of this diabetic nephropathy in India. So before that, we're going to see how the prevalence of diabetes in India. So usually 9.6% among adults are aged about 20 are diabetic. So usually see 1 in 11 in persons in India the type 2, they are type 2 diabetes. Out of see 11 persons, 1% is the type 2 diabetes. So over 53% of the adults who are living with diabetes are undiagnosed. Usually half of the population in the India they are undiagnosed. Usually most of the adults above the age of 28 or 40 who are adults, they are undiagnosed. Mostly they just we find only incidentally finding people with type 2 diabetes. So the number of people with diabetes in India is the second highest in the world. So is the highest capital of this after the China. Indians are the second place in the patient with prevalence of the diabetes. You see the 90 million people with diabetes in India. 1 in 2 adults with diabetes are undiagnosed. You see mostly 50% of the adult population are undiagnosed. I would see 1 in 11 they are diagnosed diabetes, and out of this 1 in 2 they are not diagnosed as diabetes. On 747,000 deaths are caused by diabetes in 2021. In 2021 census, we see 747,000 deaths caused by related to the diabetes in India. So because this big problem in India, because 1 in 11 people with diabetes increased prevalence up to 9.6%, and half of the population undiagnosed people with diabetes. So these are all the issues with presently in diabetes in India. So mostly we are surpassing China and will be number one in diabetes capital of the India. So we can like diabetes care of capital, number one capital in the world, and a patient with type 2 diabetes also going to be number one position in future after the surpassing the other countries China. So is usually diabetic nephropathy or diabetic kidney disease. You see what is diabetic nephropathy, diabetic kidney disease, both are similar terms. Is usually chronic loss of kidney function. So usually slowly progressive loss of the kidney function over the some duration of the time. So this diabetic nephropathy can be divided into two stages. That is a microalbuminuria or macroalbuminuria. Depends upon the albumin excretion. You see albumin excretion, that is urine albumin excretion ratio less than, that is 20 grams per minute or less than 199 micrograms per minute is called microalbuminuria. Macroalbuminuria, that is urine albumin excretion more than 200 or equal 200 micrograms per minute, it's called the macroalbuminuria. Usually approximately one third of the diabetes patients showed microalbuminuria after 15 years of disease duration, and less than half develop renal nephropathy. Usually patients with onset of diabetes slowly progressive. After 15 years, we found one third of the patients with diabetes they found to have microalbuminuria, and some eventually they develop loss of this kidney function. They end up in diabetic kidney disease. So this diabetic kidney disease is the primary single cause of end-stage kidney disease patient with type 2 diabetes. So you see the diagram is a normal kidney, patient healthy individuals. You see in the urine there is no much protein excretion, but in patient with this diabetes there is, because of damage to the glomerular basement membrane, there is a protein leaking. So you see the protein in the urine. So whenever there is a patient who usually there is a leaking of this protein in the urine, is going to damage to the mesangial cells. So when there is damage mesangial cells, there is a thickening of the mesangial cells. Finally, end up in fibrosis of these mesangial cells and loss of function of normal kidney function. So next slide, please. So this is the prevalence of diabetic nephropathy in India. So usually in urban Asian Indians, the prevalence of overt nephropathy and microalbuminemia was 2.2% and 26.9% respectively. That is nephropathy 2.2% and microalbuminemia and overt nephropathy 26.29%. So duration of diabetes, HbA1c levels, systolic blood pressure were the common risk factors for overt nephropathy, microalbuminemia. So first one is risk factor, duration of diabetes, and how is HbA1c levels, whether it is poor control, good control, depends on HbA1c levels and depends upon systolic blood pressure and other risk factors like obese, dyslipidemia, also the added risk factors for development of this nephropathy. So, according to the International Diabetic Federation 2021, the number of people affected worldwide has increased by 46% to approximately to 7, that is nearly 783 million people that are suffering with the number of people with diabetes and diabetic kidney disease. In India, the prevalence of this diabetic nephropathy ranges from 0.9% to 62.3%. So it varies from up to the 62.3% patient with type 2 diabetes they are suffering from diabetic nephropathy. So the registry data suggests that diabetes accounts for 45% of cases among ancient renal disease patients receiving renal transplant therapy. So usually our Indian registry with who are getting renal transplantation, 45% of cases among ancient renal disease are the receiving renal transplant. More patients from diabetic nephropathy they end up in ancient renal disease. Out of this 45% patients they are going for renal transplantation. So some patients may not getting the donor, some patients not affordable, some patients with other comorbidities may be premature death. So out of this 45% they are going for renal transplantation. So usually this is the stages of diabetic kidney disease. Usually stage of hyperfiltration, silent stage, incipient stage, overt stage, and actually renal disease. So this hyperfiltration stage, there is usually glomerular hyperfiltration, hypertrophy. That is usually the normal initial response to compensate for this uncontrolled diabetes. So usually we have this increased GFR, increased blood filtration rate with a normal albuminuria with just increase in GF, blood filtration rate. That is hyperfiltration stage. Followed by the silent stage. That is mild glomerular basement membrane thickening and focal mesangial sclerosis with normal albuminuria with normal GFR function. That is only there is a small change in glomerular basement membrane thickening and focal mesangial sclerosis. Next stage of incipient stage, that is mild to moderate glomerular basement thickening and variable mesangial sclerosis. So there is increased thickening and along with increased mesangial sclerosis, and there is increased albumin excretion. Here previously there is only normal albumin. Here there is increased albumin excretion from 30 to 300 milligrams per gram of creatinine. So GFR is normal or mildly decreased. That is up to that is stage 3. From stage 4 we will see that is overt albuminuria. That is marked glomerular basement thickening, diffuse mesangial sclerosis without nodule. That is with nodular sclerosis, without nodular sclerosis, and severely increased albuminuria, that is macroalbuminuria, that more than 300 milligrams per gram of creatinine with the decreased GFR along with hypertension. This is a finally stage 4 and then end up stage 5, that is diffuse glomerular sclerosis, decreased albuminuria with the GFR less than 15 ml per minute with along with hypertension. So from we need to tackle from stage of the stage to the incipient stage. When we control this glycemic control along with the decreased albumin excretion, we will prevent to end up at stage 4, stage 5. So what is the pathology of diabetic nephropathy? Why patient with type 2 diabetes they are getting diabetic nephropathy? Because of this lot of mechanisms. First one is that is change in renal hemodynamic changes. Next one is activation of the RAS. Next one is ischemia, inflammation, oxidative stress. All we have underlying hyperglycemia. These are problems. When there is renal hemodynamic changes because of hyperglycemia, there is increase in insulin growth factor 1, increase in transfer growth factor beta, vascular endothelial growth factors, prostaglandins, glucagon, endothelial 1, SGL. These all affect in efferent arterial constriction, glomerular hypertension, and glomerular hypertrophy, glomerular sclerosis. So whenever there is hyperglycemia, changes in renal dynamic changes, increase in efferent arterial constriction, causes glomerular hypertension, for causing glomerular sclerosis. Next one is the activation of the renin-angiotensin system. So whenever there increase the activation of the ROS, increase the reactive oxygen species, increase the transfer growth factor beta, and increase angiotensin 2, increase in aldosterone levels. It causes podocyte injury, decreased hypoxia-induced factor stability. Usually, hypoxia-induced factor stability decreases. It causes more damage to this glomerular basal membrane, more damage podocyte. Usually, this HIF1, that is hypoxia-induced factor, usually it prevents this podocyte injury. So, whenever there is a decrease in HIF1, that is hypoxia-induced factor alpha, so there is more damage podocytes, there is more increase in proteinuria. Next one is ischemia and inflammation. So because of ischemia inflammation, there is ages, that is advanced glycogen end products, increase TNF alpha, increase NFK beta. All this causes podocyte injury. Next one is oxidative stress. It causes activation of the JAK-STAT pathway, activation of vascular growth factors, activation of the MCP1. This all leads to tubulointerstitial fibrosis, causes tubular atrophy, mesangial cell expansion, and extracellular matrix accumulation. So, because when from the tubules, when the leakage to the protein, this protein causes sclerosis, fibrosis. So, leads to the tubular atrophy. That's why we call it as a shrunken kidney, small kidney. When this is like the final stage of diabetic kidney disease, we see the small size kidney and shrunken kidney. So this is because of this tubular atrophy and mesangial cell expansion. So because this normal glomerular cells is replaced by this more mesangial cell expansion and loss of this normal glomerular function, loss of normal kidney function, and extracellular matrix accumulation. So when because of mesangial expansion, extracellular matrix accumulation, tubular atrophy, this all leads to decline in glomerular function, declining in this GFR, and more increase in proteinuria. So how you can tackle this diabetic nephropathy? What are the strategies? How can prevent? How can prevent progression of this diabetic kidney disease? So we have some therapeutic strategies, that is by using this controlling the glucose levels and by controlling this tubular interstitial mechanism at the level of kidney. So we at least we can prevent the progression of this diabetic kidney disease. So this early initiation of combination therapy is an approach to achieve glycemic goals earlier, delay the deterioration of this glycemic control with possible better preservation of beta cell function. So positive beta cell function, better glycemic control, better preservation of this renal function. So we have novel medical therapy that is used along with the diet, exercises to control high blood sugar in order to type 2 diabetes. They are what are available medications? They are DP4 inhibitors like sitagliptin, saxagliptin, linagliptin, and alogliptin. SGL inhibitors like canagliflozin, dapagliflozin, and empagliflozin, and GLP receptor analogs, that is GLP like glucagon receptor agonist, regulate restore of incretin function. So this combination of this SGL inhibitor DP4 combination is suitable option for Indian with type 2 diabetes patient for the following reasons. It is safe, you have rapid onset of action, sustainable glycemic control. So it improves both insulin resistance and beta cell function. So both tackling both resistance and improve beta cell function. Helps reduce the body weight. So reduction in body weight decreases insulin resistance and decreases the blood pressure. Next, reduces the pill burden, because fixed dose combination you can reduce the pill burden, and by decreasing the pill burden there is more adherence to the therapy and more compliance and overall cost effective. So the SGL inhibitors act mechanism action. These both act at different levels. They have different mechanism, that is combination of these SGL inhibitors, D4 inhibitors. They have different mechanism action along with additive glycemic control. So usually these SGL inhibitors, they inhibit renal glucose absorption, so more excretion of the glucose to the renal tubules to the urine, and produces glucosuria. Along with it, promotes weight loss, decreases systolic blood pressure up to 4 to 6, decreases diastolic blood pressure up to 1 to 2, and lower risk of hypoglycemia. So it is SGL inhibitor, independent of the insulin action, independent, so no risk of hypoglycemia. D4 inhibitors, they have clinical use for like a patient more than 10 years. It inhibits that is like D4 enzyme action. So the more prolonged action of this GLP1, they think more prolonged action, more increased incretin effect, and stimulation of the insulin secretion from beta cells, inhibits the glucagon secretion from beta cells. the alpha cells, and weight neutral, and low risk of hypoglycemia. So D4 inhibitors increases insulin secretion and decreases glucagon secretion and increase the lifespan of these beta cells and low risk of hypoglycemia. So this fixed dose combination more additive effect as compared to other OADs. So this LGL inhibitor, D4 inhibitor is smart combination. So LGL inhibitor usually tackle at the level of the kidney and the cardiovascular system. So main decreases glucotoxicity and decreases plasma volume, decreases glomerular hyperfiltration. By this, so there is no decrease, that is a improvement in renal function, and decrease albuminuria. And next, a lot of this pancreas, that is because of this decrease in weight, there is improvement in decrease in glucotoxicity. So improvement beta cell function allow the pancreas, increases insulin secretion. Next, decreases uric acid levels, decreases this hyperglycemia risk. Next, allow this D4 inhibitors. They allow the pancreas, decreases insulin secretion from the alpha cells, the beta cells, and decreases the glucagon secretion from pancreatic alpha cells. So it also improves endothelial function and decreases this macrophage infiltration and decreases calcium accumulation and improvement insulin secretion, improvement this increased lifetime of this GLP-1 and GLP-1. So there is a more increase in incretin effect. So by this they allow the kidney, decrease albuminuria, decrease systolic blood pressure, decrease uric acid level, allow the pancreas, decrease hyperglycemia, decrease glucose levels. Next, allow this cardiovascular system, decreases cardiovascular events, allow this gut, the weight neutral. So all these synergetic effects by smart combination. So improvement tackling the glucose levels, prevention of this diabetic kidney disease, prevent the progression of albuminuria, weight reduction, and decrease in blood pressure and decrease in cardiovascular events. So this combination is very beneficial, very useful for these patients for prevention of the diabetic kidney disease. So this is a DAPS study. So fixed dose combination therapy of dapagliflozin and sitagliptin was effective in improving the blood glucose levels among diabetic patients in 3 months. It is an effective alternative treatment option for diabetes patients with adequate glycemic control. So we see the graphs changes in fasting plasma glucose level, change in post-mortem glucose levels for the duration of the baseline to 12 weeks. So significant reduction in both the fasting plasma glucose levels and both post-mortem plasma glucose levels along with the baseline A1C from 8.9 to the 7.2 that is around this 12 weeks. So both improvement in fasting and postpartum along with improvement in A1C levels. So this fixed dose combination very beneficial effect. Next slide please. So these benefits of SGL inhibitor in diabetic nephropathy. So what are the potential mechanisms of SGL inhibitors that is induces this nephroproduction? So what are the beneficial effects? How are you going to affect this nephroproduction? So one is the glucose lowering mechanism, that is actually glucose lowering independent mechanism, glucose lowering dependent mechanism. So glucose lowering dependent mechanism related to decrease in renal growth and inflammation because of this hyper glucose control. There is no much inflammation, no fibrosis of glomerular this mesangial cells. Next, glucose lowering independent mechanism, decrease in blood pressure, decrease in body weight, decrease in serum uric acid concentration, decrease in hyperfiltration via this glomerular feedback balance, and decrease hypoxia due to shifted fuel consumption. So by all these mechanisms, by the glucose dependent, glucose independent mechanisms, finally it is renal protective. So the dapagliflozin significantly reduces low risk of this composite of sustained decline in the estimate of GFR at least 50% and kidney disease and death from renal causes. So this diagram showing that finally from after starting this dapagliflozin, so there is a decrease in progression of renal kidney diabetic kidney disease, decrease in albuminuria, and decrease in incidence of diabetic kidney diseases. Next slide please. Next, benefits of this D4 inhibitor in diabetic nephropathy. So sitagliptin significantly reduces diabetic kidney injury by inhibiting the kidney index and attenuating 24-hour protein, reducing the urea levels, reducing serum creatinine levels, and inhibiting progressive renal fibrosis, increasing extracellular matrix, including collagen 4 and fibronectin. So the sitagliptin significantly reduces the progression of diabetic kidney disease, and by reducing this progressive renal fibrosis and increasing extracellular matrix deposition.
Thank you, Dr. Ashok, for a detailed presentation on diabetic kidney disease. We have a few questions for discussion. So, Dr. Ashok, risk factors do you look for in your patients with diabetic kidney disease? Uh, what makes you look more into patient for diabetic kidney disease? What are the risk factors that you look for?
Usually, first one thing is the duration of the diabetes and how is the glycemic control, and what are the other macro conditions where like diabetic retinopathy, diabetic neuropathy, they are simultaneously also diabetic nephropathy. So all similarly they interlink. Most of the like how is the coincidence of this retinopathy, nephropathy up to 80 to 90% of patients who have diabetic retinopathy, they have the nephropathy. Also, most of patients like 40 to 50%, they are also diabetic neuropathy. So when you clinical history
And
patient when asking any symptoms of this diabetic neuropathy symptoms, simultaneously we also look for this nephropathy and also retinopathy.
thank you, Dr. Ashok. If you have patients who have hypertensive heart disease or cardiovascular disease, how does it affect the progression of kidney disease? What
Yeah, definitely affects because patient with hypertension because of this glomerular hyperfiltration and by renal hyperfiltration, renal hypertension, it causes further more progression of this renal fibrosis and more damage to the renal tubules other than the non-hypertensive patients.
So, any guidelines or tools for early detection that you use in your OPD?
Yeah, usually routine screening we do like I do this like spot urine albumin creatinine ratio, that is microalbuminuria macroalbuminuria. I will do that for once in 6 months. I routinely do this albumin creatinine ratio and I'll pick up this whatever the diabetic kidney disease patients.
Yeah, yeah. So that
And
is what
also
we.
follow up with the creatine levels, any further any progression of creatine levels, both these parameters we can predict the progression.
Yeah. Thank you, Dr. Ashok. Uh, any evidence-based methods that physicians can use other than microalbumin, or where they should look, uh, or any other tools that can use for diagnosing diabetic kidney disease?
Tools like only like you can do by biochemically, that is like 24 hours in protein creatine ratio or 24 like a spot urea ratio. But most of the sub biochemistry labs they have like a spot in albumin creatine ratio.
Spot.
That spot we can because instead of because previously the cumbersome procedure collecting 24 hours urine is very cumbersome. But a spot protein creatine ratio, spot albumin creatine ratio is very easy to detect this albumin cases, microalbumin cases.
So, what challenges do you face? So, routinely, what we face here in my OPD is we do recommend our patients to get microalbumin test done, but I believe it is one of the most commonly missed tests, probably because of the cost or uh, the patient is paying through their own pockets. I see that this is one test that is being missed more commonly than lipid profile or, for that matter, fundus examination. What is your experience? What are the challenges that you face in your OPD?
The challenges what we do is like what kind of lab facilities they have, what kind of instrument, and how are the pre-analytical errors. We need to look for pre-analytical errors. What is the time of collection of first urine sample, or it is a random sample, and how long the duration of the getting sample. And usually, sometimes usually the most of the labs they do small like test and they say like albumin plus 1 plus 2 plus, and very difficult for our next patient to convince that we need quantity not the like 1 or 2 plus, we need quantity how much albumin expression. So after that we will convince and most like good labs, good instruments, we can get more accurate values than most of like normal machine values.
Yeah, thank you. Any specific dietary or lifestyle modifications that you advise? Any dietary changes that you advise your patient or lifestyle for
Sorry.
management of diabetic kidney disease per se?
Like mostly like guidelines, what we recommend is like firstly, strictly control for patient glycemic control along with blood pressure, lifestyle modifications, with good control of this dyslipidemia, like for patient good control of LDL levels and triglyceride levels, and like all of the risk factors. Most of the other than diabetes, lifestyle, water, most of the risk factors, the additive effects for this progression of this diabetic kidney disease. So look for all these factors and we can further beneficial for controlling solving these factors.
So, what is your opinion regarding medications like alpha keto analogs and multivitamins that are being rampantly, antioxidants that are being rampantly used for managing diabetic kidney disease by various nephrologists? Any evidence on that?
Not much beneficial effect, but usually like the anti-inflammatory, but main culprit is hyperglycemia. When we control this, tackle the glucose levels, it will decrease the oxidative stress. Along with this omega-3 fatty acids, other multivitamins, they have significant, but not much significant like glucose control. They have some beneficial effects. Control this antioxidants, anti-inflammatory.
So yeah, this can be used as an adjunctive medications, but primarily it is the glycemic control and blood pressure control that is of paramount importance. Uh, you talked about drugs, specifically SGLT2 inhibitors and DPP4 inhibitors. What is your experience on using these medications? And we have now so many combinations available with us. Your opinion regarding those?
Yeah, this is wonderful. Like the reduction of these HGL limiters for past decade, we seeing the decreasing this prevalence of diabetic kidney disease, decreasing most of the cases. We see previously before introduction of this group of drug, after introduction, we see how this most of the cases, number of people end up in end-stage disease or end up in dialysis. See, mostly we are seeing the decrease in number of cases of this patient with by adding most beneficial effect by adding this group of drugs.
Yeah, so now we have ample evidence after the availability of the DAPA CKD trial as well as the empagliflozin renal outcomes, EMPA-REG renal outcomes are also very promising. So now there is clear evidence that SGLT2 inhibitors are associated with lesser progression of chronic kidney disease, and now it has been approved for use of chronic kidney disease outside diabetes as well. Any use of telemedicine that you can suggest or digital health technologies that can help in early detection and management of diabetic nephropathy, especially like India, we know is a diverse, the ground situation is diverse. So, how telemedicine can help in that?
Yes, definitely. But once from the worker, like patient with like primary health centers or like remote health centers, just we can definitely it helps because when we can guide the where the available or the healthcare professionals, we can guide and we can prevent. At least we can give some suggestions how we can prevent this progression of diabetic kidney disease.
Yeah, absolutely right, Dr. Ashok. Just by doing the microalbumin, and probably it is one of the tests that helps us to understand the status of kidney very early in the course of the disease, and patient can be initiated on medications uh, that reduces progression of diabetic kidney disease and probably progression to dialysis or end stage renal disease as well. So it can definitely make a lot of difference, and telemedicine plays a huge role in that. So that's all from our side, Dr. Ashok. It was wonderful having you here, and thank you for coming. Any last line or any last message you would like to give to our audience?
Yes, thank you for a wonderful discussion. But patient who taking like the doctors, healthcare physicians, or practitioners who tackling with patient type 2 diabetes, don't look for only the glucose levels. Look for the patient with comorbidities. Look for the creatine levels. Look for this albumin creatine ratio, microalbumin. When we pick up this microalbumin, patients like we can prevent this progression of the diabetic kidney disease. So be cautious with patient with type 2 diabetes. Which is most of the Indians population, like we see how the prevalence. So once we tackle early, we can prevent this progression of the end-stage renal disease. We can save the lives.
Yeah, absolutely right, Dr. Ashok. We should not just be hinged on creatinine. Probably it is a microalbumin that is more clinically relevant test, especially in the early part of the disease, where we can actually make difference in our patient's life. Because once creatinine has started rising, probably we are late. Probably we have lost more than 50% of the glomeruli, and we are late in managing the situation. So it is earlier detection through microalbumin urea that is important. Thank you, Dr. Ashok, for a wonderful discussion. And with that, I'll hand over the session back to